Emma Botchett. Was that close? Bam! I did it right. Emma, wave to the people. She's our dental specialist, and we're very lucky to have her at DCH. She's been doing a lot of work associated with the expansion of adult dental benefits. So always start off with our purpose, shaping the future of healthy Georgia, access, quality to strengthen the communities we serve. So I wanted to start off with kind of the conditions of participation and just do a reminder. How many providers do we have in the room? Okay, a few. You probably know there's a dental provider manual, right? I'm hoping you know there's a dental provider manual. I'm going to say that and just, even if you don't know there's a dental provider manual, lie to me and go, yeah, there's definitely a dental provider manual. But you also should know, if you don't know, that there is a Part 1 policy and procedure manual for all providers. And whatever provider you are kind of in our network, if you are a waiver provider, if you are a physician, if you are a hospital. I'm the policy guy, by the way. My name is Brian Dowd, and the presentation won't be linear if you didn't just figure that out, because I kind of go around the bend sometimes. So I'm kind of the policy director, deputy director at DCH, so I talk a lot about policy. And often when I do presentations, people are very aware of the fact that they have a policy manual for their program. They'll be like, yeah, I know, Children's Intervention Services, OTPT speech, there is a policy manual for that. And then I will reference the fact that there is a Part 1 policy and procedure manual for all providers, and people will look at me and go, what? I have no idea what you're talking about. So there is a policy manual out there on the GAMIS website where you see the dental manual or any other manual that covers all of our providers. And it's really, really an important policy manual because it covers foundational things for being enrolled in Medicaid. And when you enroll to become a Medicaid provider, I'm just going to throw this out there, you attest under penalty of perjury that you have read that policy manual and you kind of understand the basics associated with the policy manual. So a lot of times I'll get questions where people are like, Brian, you have no idea what you're talking about when you say this is in there. What policy manual are you even pulling this out of? And I go, oh, Nellie, you really have to be able to be familiar with the Part 1 policy and procedure manual. So I'm just putting it out there in case you aren't familiar with it, that you can reintroduce yourself, not sound like Jay-Z. Who is a provider? So in the dental world, well, let me start with this. So here's the basics of what's happening. I started 28 years ago as a age-minded disabled case manager in DeKalb County DFACS, doing like eligibility determinations. And I didn't know anything back then, and I was like 26 or something, so I really didn't know anything. And one of the first questions I got, like within the first week of coming back is, because I worked with age-minded disabled people, right? I got, hey, I got stuff going on with my teeth. What do I do? And I was like, let me try and figure that out. And I quickly learned, we don't do anything, right? Like the Medicaid program pays for extractions. It pays for surgeries, like if it's some surgeries. But like if you have a cavity, we don't pay for that, right? Historically, we have never paid for that. So I don't know about everywhere, but at DeKalb, we had a little thing in the waiting room. It was just pieces of paper that we had stapled together for free or discounted dental services for adults, where you could go to a free clinic that would be every Tuesday, or there would be some doctors that would do a sliding scale. A doctor was a doctor that went into the public health department. So for a good 27 years now, I've worked in Medicaid, 27, 28, something like that. I started in 96, so whatever that is. I've been getting asked this question, like, why do y'all not cover anything for adults? I've been getting papers about how if adults don't get dental care, it leads to all these other systemic health issues, right? I've read the stories about people in nursing homes who have gotten proper dental care and been released from nursing homes back to the community. And I've been like, well, it's never been part of our plan and we've never been allocated the money. So here's what happened. Last year we got allocated the money, right? So yay, right? We sent in a state plan amendment. So our Medicaid program is a state plan. Just like if you have insurance, you get a booklet every year that says this is what we cover, this is what we don't cover. Medicaid has the same thing. It's available online. It's called our state plan. It talks about how we administer services and what we cover. So we did an amendment to our state plan and requested that effective July 1st, 2024, thank you, no concepts of time anymore, 2024, that we would start covering adult dental services. So we are now, as of July 1st, covering adult dental services. Yay, right? Yay for the dental people. And yay for our members, because they actually should have some access to dental care. Now, Emma's going to have to nod to me. There's two different categories of service. There's 450, which is pediatric dental, pediatric dental services. Thank you, everyone, for just correcting me mid-presentation. I do love that, actually. And now, and there's always been another category of service, which is 460, which is adult dental services. So you, as a provider, need to make sure that you are enrolled in both categories of service if you want to start serving for adult dental services. I think many of you already are. It's just there wasn't anything for you to access out of 460 because we only did like extractions and stuff, right? So when I wanted to start there is kind of why we're here today. That's the great expansion that is happening for our adult population. And also, let me just say this as well. Right now, many of our adults are covered out of fee-for-service Medicaid. Because the SSI population, the folks who receive supplemental security income, are our largest group of adults. Right? So they're in a fee-for-service model right now. That will eventually change down the road in a few years. But right now, they're in a fee-for-service model. So you would bill them out of straight Medicaid. You would not bill them through one of the care management organizations. So who's a provider? If you want to become a provider, these are the conditions about being a provider. Current valid license, and these are the different conditions that are associated with being a provider. Most of what I'm going to show you today is straight out of our policy manual, just condensed in a way that's easier for you to see and that we can post later and it'll be easier for you to reference back on. So this is our billing agreement that's associated, and this is way too much information to put on a slide. I used to be a trainer at one point in my life, and you know you're only supposed to have like 7 words on a slide for it to be effective, so that's really terrible. But these are the general conditions of being able to bill. And what that really is just saying is that you're going to bill in normal accordance with your practice license and with billable codes, right? You're not going to do anything clever. You're not going to bill for another provider. You're not going to bill for codes that don't exist. You're not going to do one service and call it another service and then upbill for that charge, right? You're just going to bill for the services that you render. Documentation of services. I'm putting this in because I get this question everywhere I go. You need to document every service you do or we don't know that it's happened, right? And so that has to be 5 years from the date of service for all claims. You need to, again, agree to bill the department with the code that is most appropriate for the service that was rendered, and you have to retain those dental records and their corresponding and dental visits in case we have some sort of auditing function that is associated with your dental claims. I think I saw Melanie Wilson come in the room. Did she leave?
No.
She's all the way in the back, so y'all won't be able to see her. Wave to the people, Melanie Wilson. Melanie Wilson is our point person who is in charge of payment error rate measurement, which is one of our giant audits we do, and it's about to start up right now again. So the federal government comes in, they look at our claims from start to finish, and if you get selected for that claim process, you will be reached out to and said, hey, we need all your documentation on this claim. And if the claim is not valid, two things happen. One, the federal government asks for the money back, right? They're like, now you're just billing for stuff that we don't have any proof that you should have billed for, so give us our tax dollars back, right? And two, the state of Georgia gets dinged for not having a correct case. So we will get like an error rate that's associated with it. So it's really important that you document your services. I also get a lot like, what is a proper and valid record? This is a proper and valid record. I'm not going to go through all of these points with you, but these are specifically in your dental manual to help both of us ensure that when we do get these auditing entities and people do come in and say, hey, are they doing what's appropriate, that we can say, no problem. Here are our claims records. It has all the points that you guys look for typically. Which are these points? So here's the interesting part. And I've gotten a lot of questions about this. And that is, okay, so what are y'all going to cover, right? And our budget instructions for the legislature said, cover everything that you cover for children, right? Which is, I know, shocking for people when I say this. It was shocking for me too. It was very shocking for Emma. Emma was like, no, we're not covering everything. And I was like, that's what our budget instructions are. We're supposed to cover everything we're covering for children, for adults. Now, we have since gone through some of our codes. We have a dental work group that Emma works with, along with Juanita Hines. I don't think she's in the room right now. But Juanita Hines and Emma have been working with some actual dentists and providers to look through our dental policy manual to see what's old, what's antiquated, and also they've been giving some guidance to us on certain codes that just wouldn't be appropriate to bill an adult. They're child-specific codes. So those codes, of course, wouldn't make sense for you to bill for. But again, according to the previous slides, you wouldn't bill for them anyway if you knew they were child-only codes. But we are covering diagnostic, preventative, restorative, prosthetics, orthodontics, everything that we cover for a child now, we will be covering for adults. I know many people have gone, wait a minute, that's a big ticket item, right? So we get budget instructions on what to cover and what not to cover and associated tax dollars with it. When a budget comes out or a law comes out, we are required to follow those instructions. If then it's like way more money than they thought, then we have to adjust to that in our state plan. But we'll build the program according to what our budget instructions and our guidance was. So that is what we're doing. So basically what that means is all medically necessary dental services will be provided to recipients 21 and over when they're at the normal intervals and reasonable standards of dental practice. All services, with the exception of emergency services, will require prior authorization. Do I have that right, Emma? I'm just always looking to Emma for something I put in the presentation where she's like, that ain't right. The only limitations we have on the services right now are investigational items and experimental services. And of course, anything that's not medically necessary. That's a basic rule of Medicaid anyway, right? Everything we provide is something that has to be medically necessary. We're not doing things for convenience. We're not doing things for, just to make folks' teeth look pretty. But we are doing things if they are medically necessary. So what's next? Is that highlighted? Oh, it's highlighted. So this is a big change. Just one sec. Let me just go through this, and then there'll be tons of time at the end, because I'm almost done. I think I have one more slide. It's a big change for us. We basically have to take all the codes that exist in category of service 450 and move them to category of service 460, along with all the other tasks, the 54 tasks that Stuart talked about this morning. So in the midst of all of that, we're trying to make this system change to put all those new codes into 460. I don't have a specific date when that will happen for you yet, unless you have one. Monday?
It'll be in Monday.
Oh, isn't that amazing? So I'm not gonna, y'all don't come looking for me, but Emma says Monday. All those codes are going to be live in category service 460. That's Emma, the dental specialist, told y'all those codes are going to be live. Good for you, Emma. That's really impressive. So one thing we will also be doing on top of that, so that cuts this slide short, we're going to go back and mass reprocess claims to July 1st. So if there was a claim that you billed, right, back to July 1st for an adult, and it's sitting out there in a denied status because we don't cover anybody 21 and over, the system will catch that and release a claim payment for you. And we have instructed a line to do PAs back to July 1st as necessary. We did instruct you that, right? See, look, everybody's in the room with me. I so appreciate it when everybody comes, so I'm not lying to people. So if there are PA requirements that you need through Alliant, then you can use the normal course of business that you do to submit a PA request through the PA portal. Still getting nods. And they will review those back to July 1st. Now, it usually takes a few months for us to do a mass reprocessing. Give us at least 90 days for that. Because I know we have a bunch of them right now. We have some for now on comp, one of the waiver programs that we're having to do in batch cycles that's quite large. We're having another one for behavioral health that just got approved, and that's going to be a massive claims reprocessing as well. So, two last things, and then I'm done. Ask whatever questions you want. This is where you get our provider manual that is specific to the dental program. And they will post this presentation after it usually takes like a couple of days, a day or two, but then it'll be on the portal. So Gainwell usually puts them up like within 48 hours. They're really quick about it, getting them up there. And so then you won't have to, you can just go in and copy the link. Also, I want to really encourage people, if you don't look at your banner messages, that's how we communicate to you all. So everybody knows where looks at their remittance advice, right? Okay, so there's a thing out there, I'm just going to say this, there's a thing out there called a remittance advice that goes to you every week, and what it does is it kind of tells you how much you get paid and who you get paid for, right? So we'll give you a claims by claim, this got approved, this got denied, why this got denied. Sometimes I say this to people and they're like, remittance advice? What is that? And I'm like, well, that deposit that went into your account, there's an accounting ledger to it that we also send you. And the other important point why remittance advice is important is because we often put messages to our providers on the RA. So that you guys, because we figure that's one place y'all are probably really looking all the time is your remittance advice, and it's a good place for us to get in contact with you. But this is also the link where we put all of our banner messages. So you can go back and look at any time the Department of Community Health is trying to say something to all our providers. They're just listed there forever. So you can go and look at them and see what it has to say. Sometimes we have to do stuff outside of policy manual cycles, and we want to let you know that a change has come really quick. So we'll throw it on a banner message to make it enforceable. So make sure you know where the banner messages are as well. Okay, I told you this wasn't going to be a long presentation, less than 20 minutes. That's about as much as I want to talk anyway. So questions, concerns, comments for me, Emma, Alliant, anyone else who's in the room?
Thank you so much. That was a very insightful. We really appreciate taking the time to put and clarify a few things. First of all, I don't operate five dental practices. We get called all the time for adult Medicaid. Adult Medicaid services, it's defined here medically necessary. So would you clarify that, number one? Number two, pre-authorization is very challenging for us. There's no way I can keep up with seeing kids and adults, and nobody sees Medicaid adults, as you know. In Georgia, it's pretty challenging because the fees are very low.
Correct.
So we often get walk-ins, often get calls, it's really thousands of calls come in on a daily basis. So can you clarify a little bit about these restrictions as far as the pre-authorization? What's commonly approved, what's not, so we don't have to waste the patient's time and waste our team time?
Sure. So let me address a few things there. So there is like a federal and a policy definition in our Part 1 policy and procedures for what's medically necessary. Don't know it off the top of my head, but it's basically, and to put it in layman terms, for you on your license, right? For you on the jeopardy of your license, when you look at a member and you say, hey, this is medically necessary. This is something to correct or ameliorate the person's condition. That's what we say to a child all the time. That they need this procedure in order to, live healthy, normal, active life. That's generally the layman's version of medical necessity. But I'd be happy as part of this to kind of pull that out for your viewing. Another thing that you talked about was the rates. So this is something that if you've been in a presentation with me before, you've probably heard me say, we don't do bake sales, we don't do car washes, right? We are not a private insurer. The money we give you is tax dollars. It comes from people. It does not come from profit. So we don't have the authority as the Department of Community Health to go, even in areas where we see the rate may need adjusting, we don't have the authority to then go in and say, I'm going to do a rate increase because we have issues, because there's just simply not the tax dollars that are available to do that. It's a little different than like a Blue Cross Blue Shield situation where they do run on a profit margin and they can up or down that rate amount, right?
Well, it is not just the fee itself. As you know, with the labor market, it's increasing. And for any individual, we're running a private entity as well. So when I bring in a provider or a hygienist at $60 an hour, and my fee to do a cleaning for an adult is $35 or $40, it becomes a challenge. So for us to understand that parameter going into it, which is really very helpful, I get the medical necessity. I think it's all related to a lot of heart conditions, some other situation that we have to intervene and clear up or give the patients a letter. So adults, it is a great services, but it comes in with a lot of check and balances that we have to visit, and that's on your website as well, right, for the rules and regulations for the.
Correct. What is covered will be in the policy manual as well. Let me address your prior authorization concerns. So I haven't in this category of service dug too deep into the prior authorization issues. I have in other categories of service like autism and some other services related to hospital and physicians. We at the department always welcome if you are coming up against normal issues, denials of prior authorization, things that you think take too long, whatever your process and procedure are that you hit glitches in, we're always willing to take that information in and see if we can improve the process for you. We are not trying to put barriers in place to service. We are trying to make sure that both you and we don't get in trouble with authorizing services that aren't necessary. We don't like it when our providers go to jail. I mean, I know I've done this now 28 years. I love when someone comes to me and says, a doctor would never put their license in jeopardy for fraud. I've been to 8 cases over my lifetime where a doctor has gone to jail. So I don't necessarily buy into the fact that, there doesn't need to be a check and balance in place for ensuring that what is being requested is really valid and necessary. But we don't want to put something in place by where there's no need for it to be there. If there's a service where it's like, this doesn't make any sense to have a prior authorization, this is only something you can do once every 10 years or something like that. And then it becomes a question for, why do we have a prior authorization on this? If it's something on the website that is difficult to navigate or a drop-down menu that we don't understand, we can do clarifying things in order, including videos that say, hey, this is how you fill out a prior authorization to make things easier. So I encourage you to feed that back to me.
I'll give you the feedback because we've got several doctors that I operate myself. Nitrous oxide is very common among kids. And honestly, we're trying to make sure that we calm the kids all the time. So for every procedure, given a nitrous oxide, you just don't know until you put that child on the chair. And we noticed probably half of the CMOs now, they're denying the claims because they're requesting pre-authorization. So here I am, patients in the chair, parents took time off, that I'm going to stop, and I'm going to tell the parents, hey, I have to give you the nitrous oxide, but your insurance is not, or the Medicaid, we're not going to be covering it, so I'm going to go ahead and carry on the procedures regardless, and we're going to file a claim, we're going to lose money. So ultimately, we're going to start going back into, do we waste the patient's time in some of these procedures? You just don't know until you get into it. What is the parameters and where are the happy medium between those two?
They're frequently put in place because of fraud. Because of fraud studies that have been done and where large amounts of money have been taken back and where legal action has been taken against providers. That's the truth. That's where you see prior authorizations come in, where we see abuse of the system. So, I am more than happy if you want to, because I'm imagining it's not just a nitrous oxide issue, but if it is, and that's the only one, then I can bring that back.
I think the nitrous oxide and the fluoride, take-home fluoride for these kids, that it's really very helpful for that age group. I mean, the more we prevent cavities, the less procedures we do. And honestly, the more I educate the parents to utilize some of these things, the better this child is going to be. Because I don't want to do a root canal on permanent teeth. It becomes a challenge for these kids. And we've seen it more often. It is where to start from the beginning. So those prior authorization for fluoride, it is.
So those are your two, nitrous oxide and fluoride?
Yeah.
Okay, well, we can take those two issues back.
Yeah.
And if you have other issues that are related to prior authorizations that are about the website or the process, you are welcome to send those to us as well. Okay?
Is there a number we can send it to, or is there...
You can send it directly to my email address, If you don't know my email address, it's bdowd, my first initial and my last name, bdowd @dch.ga.gov. And I won't repeat it. So if you didn't get it, you're just out of luck. No, I'm joking. If you do need it, just ask me and we'll give it to you. But it's just my first initial and last name, and then the same thing you do to everybody at DCH, which is at dch.ga.gov. Okay? And that goes right to me. It like doesn't go to a filter. Now I will say this, and this is not a joke, and people think I'm joking when I say this. I get 300 emails a day, somewhere between 300 and 500. So if I don't respond immediately, it's not because I'm ducking you. It's because I get 300 to 500 emails a day. Like I get like 150 on the weekends. So it may take a little bit of time for me to respond to you, and I'll probably have to corral in Emma and Juanita and some other people on some of these. Like for the prior authorization issues, if you send them to me, I'm going to want to engage on Lion and see what's going on with the PA portal as well.
I'm glad that was actually brought up because I'm a provider for DBHDD, so we do have a lot of clients that are, I want to say childlike. So with that, as far as them getting the assistance as far as with the dental, we will have those issues where they may have to be put to sleep. So we definitely need to make sure that Medicaid is covering whatever extra things need to be done for them.
Okay, I mean, it is a covered service. I think the issue is about when and the process of prior authorizing. And of course the rates. I hear you with the rates, and I'm going to, because I can't officially encourage anybody to do this, but take that to the proper channels, right? I know I'm on camera right now and I'm about to get in trouble, but guess what? I'm also a year from retirement and I can retire right now. So I'm in that beautiful zone where it's like, what's the worst that happens? Right? They fire me and I just retire, right? So it makes me a lot more talkative than I was when I was, say, 20. But like, I get all the time. So I go to a Medicaid provider for my own dental work, right? I cannot get out of the dang provider without being corralled by the dentist who want to talk to me about the rates. There was one time I was like covered in blood, and there were like 3 dental providers around me talking about rates. I'm like, can I just get this issue dealt with so I can leave? Like, I just need my teeth right? And so it is really important that as, providers, you are active in your associations or whatever mechanism you use to advocate for your programs, like on a legislative level. We as Medicaid have a couple of ways that we establish rates. We can do market rates, right? We can do a percentage of Medicare and Medicaid. That's a valid rate methodology. We can also do a rate study. We can send information out to see what it actually costs dentists to deliver services. And then we can do rates according to that. But here's the little trick. We don't have to, once those rates are in the system, we don't ever have to touch them again. Like, it's very rare that the federal government or anybody else will come back to a state and say, hey, your rates are off. Do something with this. They wait for a state to take an action. So it becomes really important that there's like a valid rate methodology for ensuring that your rates are appropriate. I'll probably get in trouble for that at some point, but we'll see.
How will this change affect CMOs as we list this benefit as a value-added benefit right now? And what are the changes?
So that's a great question, and I forgot to mention one other thing that I need to mention. So right now for pregnant women, we have this weird rule where we stop dental coverage once they give birth. So for now, they're going to be adults that are covered, right? And so we also expanded the postpartum period for up to a year, right? We used to do it for 90 days, 60 days. I'm talking about their eligibility. Their eligibility, I think it was either 30 days or 60 days post termination of the pregnancy. Then they would lose their Medicaid benefits and stop dental benefits as soon as they gave birth. Now they have a year-long postpartum period. They will continue their dental benefit for that year-long postpartum period. The CMOs used to offer parts of adult dental. That's why you reminded me of the pregnant women, because the CMOs continued dental services for pregnant women as long as they had coverage. That was an added benefit that the CMOs were giving to their members. Now, it's a required benefit. So here's how it changes. It's no longer an added benefit, right? Because now the CMOs in their capitation payments will be able to say, hey, we're paying for something that is required, right? So that's one of the things when people come to us and say, we're giving you $2 million to include this code, we often have to say, well, that's just fee for service. Remember, we've also got to do it over here in these populations, so we've got to figure out how much that is going to cost us in our CMO capitation payments. What else? Anything else? Yeah.
Another issue, does the Georgia Department of Community Health have pressure on the CMOs to get the credentialing doctors faster, or just kind of speed up to get a provider online? Now you added these adult services, we need to work on bringing more providers, but if it's going to take 120 to 160 days sometimes to get these providers on board, what kind of a pressure you guys have on the CMOs, since they are contractor on your behalf, right?
Mm-hmm. They absolutely are. So I am gloriously not the CMO guy. I am the fee-for-service guy, and I don't want to get too far out of my lane, but we absolutely, positively do have contractual requirements with the CMOs about enrollment, which is basically what you're saying.
Do you give them like timetable or no?
I think, but I don't know what it is off the top of my head, so I don't want to say. I know it is something that Maxine Elliott's unit monitors. So if you don't know who we are at the DCH, it's sometimes really important. I would really encourage you, and I'll bring this back to Maxine and Shanique Horn, but they are the two, Maxine Elliott, Shanique Horn are the two people who are over like the CMO compliance section, and they're the ones who make sure that all the contractual points are being followed, or we issue liquidated damages and that sort of thing. I know it's something that's tracked, I just don't know what the measures are, because it's not what I do.
So these contacts on your website for Maxine?
I don't know if their contacts are there. There are, I follow up to this, I can send out the managed care, there's specific email addresses that we use for managed care concerns, complaints, inquiries. They're like set email addresses, and the reason we do that and not to a specific person is when you get into a contractual arrangement, it's really important to be able to track those responses. And when the CMOs, so we can get you those follow-up emails as a part of this, so you can send in that question and get a formal response back. Okay? One more. Not one more. I've got forever. I mean, my presentation was very short.
Going back to the pre-authorizations, I can imagine that as we, as this expansion happens, the number of pre-authorizations is going to increase significantly. So, are there more on your end? Are there more people processing? Like, how long should we expect a pre-authorization to come back?
Do you know what the requirement is for auth review? It doesn't change though. It hasn't changed. We haven't extended the timeline out for this.
Okay.
So it's part of our existing contractual arrangement. Often when we add something new, almost always when we add something new, we account for it in our contract with the authorizer, right? So, like, you know, Lion has been a very good partner for us over the years. I think I've been like the contract person for them forever. I don't know, 15 years, 10 years, something like that. They often do things that, they work with us very well, right? But they also are very cognizant of the fact that, like, hey, Brian, you can't add 2,000 more PAs and we not have any employees to look at these 2,000 PAs. You're going to clog up the system. So we have a communication back and forth that is like, okay, well, what will it take then? And then that gets communicated back to the Office of Planning and Budget with the governor's office and the legislature to say, you can't just add the service dollars. You have to also add the administration dollars or it's not going to work.
Is there somewhere we can offer that feedback? If it comes down to that?
Yeah,
I think
absolutely.
it'll be great, and we won't be
Emma.
having that. Okay.
You talk to Emma, and Emma will give you her email address. Emma, it's Halloween, don't roll your eyes at me. Emma is very excited to get your concerns and questions. She told me that right before this. She said, Brian, make sure you introduce me and make sure that I let people know my email address. Which is your, Lord knows I won't spell your last name right. But maybe you could tell people what your email address is. Go ahead, take the microphone down.
First initial E, last name is BOAKYE at Georgia.gov.
dch.georgia.gov.
It's EBOAKYE at dch.georgia.gov.
Thank you, Emma. Another question?
So, I'm a provider, and
Uh-huh.
I'm the chief dental officer at my health center in DeKalb County. When I first heard about this expansion, it was through a grad student that I've been working with about advocacy. This was like 2 months ago, and it was news to me. And I feel like I'm pretty attuned to what's going on. I started shooting emails to everyone I knew, like other COOs, other extra HCs, someone on the board of dentistry, and no one had heard about this. And for a while we were like, is this for real? Is this fake? And then I got a link about this fair, and it was on the agenda.
Mm-hmm.
So I guess my question, my comment is that this is huge, and this is really exciting for our communities, but I don't know that anybody knows about it. And so, like, sort of just what's the process for getting this information out to providers, to clinics, to the community?
Right,
Yeah.
so we did a banner message. I'm trying not to go back to what I said before, that y'all don't read your banner messages. I'm trying to say full of love and light today, but y'all always press me into a place that is not full of love and light. It was also on our website. It was also a big legislative initiative that was like kind of championed through last year's legislative process. We also did, I think, communication on our Twitter. Do y'all know we have a Twitter or whatever it's called now? I'm not a tweeter, so I have no idea. And I think we also have like a Facebook page where it was put up. So I know that this went through our communication channels to say, hey, this is a new benefit. We also communicated to our sister agencies, folks like the Department of Behavioral Health and Developmental Disabilities, because we recognize that through the waiver programs, they actually work with a lot of our elderly and disabled population, as well as the Division of Aging Services and others. So that's our normal points with it. We haven't done like commercials or anything, because that's not kind of what we do. But we do communicate through those avenues. We're welcome for suggestions, but like we're not going to do. It's also like I'm not going to do commercials. That's not what we're going to do. I mean, there's also that aspect. Anything else?
I'll always have
Did I mention Emma is the
Yes, and we gotta get to know each other a
Emma,
lot.
I suggest you.
So, the Georgia Department of Health has a budget for the amount of dental allocations per year. Do you guys, when you set up the budget earlier of the year, if that budget got depleted by services?
Yeah, so let me, I know where you're
Can you
going.
walk me through that process a little bit?
Yeah, so let me tell you where that goes. So, and I'll do it outside of dental, and again, this will probably get me in trouble, but don't care. So, in 2017, I was asked to stand up the state's first ever autism therapy program, right? But Brian, we've never done autism therapy. You gotta stand up this program, and you got 6 months to do it. And by the way, you got $60 million, right? Everyone I spoke to, and I mean everyone I spoke to, said, Brian, do you know how much more than $60 million this is going to cost the state of Georgia? And I said, not my problem. Like, I was told to stand up an autism program, and then they're going to have to figure out the money on the back end, right? We spend way more than $60 million on autism therapy at this point. So the way it works is when we add a new service or do a rate increase or anything, the department is contacted by the legislature and or the Office of Planning and Budget, which is the governor's money people, right? And it's usually both, and they say, how much do you think it's going to cost to cover adult dental? And the three entities work together to say, we think it's going to cost X amount in state tax dollars. Because all our legislature is responsible for is the state match, right? 2/3 of Medicaid dollars come from federal tax dollars. So it's not that we don't care about the federal tax dollars, but we care about the federal tax dollars, right? We only care about the state tax dollars because that's what's coming out of our budget, right? So then, once that is in there and it goes into the state plan, we have made the change to the state plan. Regardless of how much we spend, it's in the state plan now, so we're required to do it. So if we go way over that target, one of two things will happen. Either they'll have to allocate additional tax dollars to it, which typically happens because it becomes part of our base budget every year. Or they will come back, the legislature will come back to us and go, okay, we made a mistake. We're spending way too much money on that program, and we're going to have to put some guardrails around it. It's very rare that that happens, though, because it's a lot easier to give a benefit than it is to take back a benefit, right? So the question I got all the time with autism is, what happens when we get to $60 million? Do kids quit getting services? The answer to that is no. It's then in our state plan. So regardless of how much gets spent, we have to pay for what is in our state plan. Now that doesn't mean it doesn't have consequences for the future, but that's the way we work as a Medicaid agency. And those consequences would be, quite honest, let's say that we ended up spending $1 billion in adult dental, right? And they were like, oh my God, you just spent $1 billion in adult dental. Then we would have to go through our normal process to make a change to our state plan. So I'm going to get back to your question again too, because this happened with adult dental. Y'all know we have board meetings, right? They're the second Thursday we are really not a secretive agency. I mean, people love to say we're like a secretive agency, and I'm like, oh no, we're not. We're really not. That's just not true. Every Thursday, second Thursday of every month, we have a DCH board meeting. Any change we make to the state plan, we present to the board. We do town hall, like public notice meetings where you can come and make comments. You can fax comments, you can email comments. And then we have to go the following month or 2 months later to the board and say, we got these 10 comments. And here's what they all said, and here's how we're addressing it. And that's another way we communicate to providers in the general community. These are new things we're doing. These are changes we're making. These are rates we're adjusting. So if we did have to go back and reduce the benefit, it would have to go through our public notice process as well. My time now? Because my voice, I need my diet sweat. All right, John, if there's no other questions, I want to thank you. Oh, wait, Juanita has one thing. You come and introduce the folks, Juanita. I'm going to move over because my throat's getting weak. This is Juanita Hines. She's our policy manager at the Department of Community Health, both of her eligibility and services.
Thank you, Brian, and thank you each for attending. And I really wanted to, because I'm quite excited about the expansion of dental and dental support. I'm just very pleased. Commitment from legislators, Brian Dow, as well as Stuart Cortland, and collectively policy at large. But I also wanted to acknowledge the work of the Dental Directors Work Group. Dr. Judy, Dr. Amber, Dr. Mindy, who have taken time out of their schedule to really review the dental services policy manual, to bring it up to speed, and to represent current practice. It was just a heavy, heavy lift, and without hesitation, the commitment has been there, so we greatly appreciate it. So if you all would stand, please. Dr. Judy, Dr. Mindy.
I was going to make y'all do that.
And we are very humbled and very appreciative because it really is about the member and our members. And anything that can make a difference and an impact when it comes to improving practice as well as access to care, that is our vision and it is our mission. So again, thank you.
Thanks, everybody.